Hello everyone. Today we will discuss about post-menopausal bleeding and cervical growth. Post-menopausal bleeding is one of the commonest gynecological complaints you will see in the gynecological wards. Along with it is an important short notes question. What is menopause? Permanent cessation of menstruation due to ovarian failure. It is diagnosed after 12 months of amenorrhea and average age in India is roughly around 47 years. It is happening due to decline in estrogen and progesterone. Significance of postmenopausal bleeding. Any bleeding after menopause is considered as abnormal and the malignancy should be considered unless proven otherwise. It requires a very thorough evaluation. The most common causes can be due to genital causes, ovarian causes or systemic causes. Uterine causes include atrophic endometritis, endometrial hyperplasia, endometrial carcinoma and endometrial polyps. Cervical and vaginal causes include carcinoma cervix, chronic cervicitis or erosions, vaginal or vulval carcinoma, trauma or atrophic vaginitis. Ovarian and iatrogenic causes include estrogen secreting tumors like granulosa cell tumor, hormone therapy, tamoxifen, anticoagulants and coagulopathy. See, imagine a 50-year-old woman presents with a postmenopausal bleeding and a visible cervical growth. What we should be doing? First is we have to confirm there is a menopause. Then take a detailed history, perform clinical and pelvic examination, investigate them systematically and manage as per the diagnosis. First is age and parity. So age of the patient, the number of pregnancies, a mode of delivery. This will include, if it is multiparity, this could be chronic cervical trauma or carcinoma cervix. Nulliparity means prolonged unexposed estrogen might be due to endometrial carcinoma, and possible differential diagnosis include carcinoma cervix and endometrial cervix. Time since menopause and last menstrual period. So the duration will reveal a pattern. Duration since menopause, the pattern of cessation of the menses and any use of hormone replacement therapy as well as during the postmenopausal phase. So if it is recent menopause, that is less than 2 years, it can be atrophic endometritis, or long standing, that is greater than 5 years, can be due to endometrial or cervical carcinoma. So here the possible differential diagnosis can be atrophic endometritis or vaginitis, carcinoma endometrium, carcinoma cervix. The nature of bleeding, if it is sudden or gradual, and the duration and frequency also along with the amount of bleeding. If it is just a spotting, there could be atrophy or polyp. Heavy or recurrent means you should rule out consider malignancy, and postcoital, then there could be carcinoma cervix. So here the possible differential diagnosis can be carcinoma cervix, endometrial carcinoma, endometrial hyperplasia or polyp, and atrophic endometritis. Associated symptoms, if whether it is local, that is foul smelling discharge, postcoital bleeding, pelvic or back pain. So here the foul smelling discharge can be necrotic cervical growth, the postcoital bleeding, friable cervical lesion or pain, that is parametrial invasion or pelvic spread. Again, the possible diagnosis are carcinoma cervix in advanced stage, chronic cervicitis or endometritis. Associated symptoms, that is systemic ones. Urinary frequency like dysuria, hematuria, bowel, constipation, tenesmus, whether it is constitutional, weight loss and appetite loss. So here there will be bladder invasion, bowel symptoms, rectal invasion and weight loss like malignancy and metastasis can happen. So here again carcinoma cervix and carcinoma vagina or endometrium. Drug history, any use of hormone replacement therapy, tamoxifen for the use of breast cancer or anticoagulants. In case of hormone replacement therapy, consider endometrial hyperplasia or carcinoma as well as tamoxifen usage. Consider polyp or carcinoma endometrium. If it is anticoagulant, there can be exaggerated bleeding. Here the differential diagnosis can be endometrial hyperplasia, endometrial carcinoma and iatrogenic bleeding. And the medical history, if there is any associated hypertension, diabetes, liver or coagulation disorder. So here diabetes plus obesity plus hypertension, there can be corpus carcinoma syndrome, that is risk of endometrial carcinoma, and liver or clotting disorders can lead to bleeding tendency. Here coagulopathy related disorder and endometrial carcinoma are the possible diagnosis. Obstetric and gynecological history, parity and spacing, mode of previous deliveries, any previous cervical procedures or pap smear results. So in case of multiparity carcinoma cervix, and history of abnormal pap smear can be due to previous dysplasia and previous cervical cauterization or cryotherapy and recurrent lesion. Here consider carcinoma cervix, chronic cervicitis erosion or post procedure fibrosis with infection. Any family history of malignancy in close relative, especially breast, ovary, colon, and endometrium, may suggest inherited cancer syndromes like Lynch syndrome, HNPCC, BRCA mutation. So here, hereditary endometrial carcinoma or ovarian carcinoma should be considered. Personal and social history, tobacco or betel nut chewing, sexual history, hygiene, socioeconomic and nutritional status. Here, because of poor hygiene, early coitus, multiple partners, HPV risk, low nutrition, and poor immune defense can lead to carcinoma cervix or chronic cervicitis. General examination findings like pallor, cachexia, lymphadenopathy, weight loss suggest advanced or systemic malignancy. So here, chronic cervix, metastatic endometrial carcinoma. Then local pelvic examination like cervix, growth, ulcer, bleeding on touch, uterus, the size and mobility of the fornices and induration. Here there can be friable growth like carcinoma in case of carcinoma cervix, enlarged uterus in case of endometrial and carcinoma fibroid. So here the possible differential diagnosis can be carcinoma cervix, endometrial carcinoma or leiomyoma. So the clinical features include irregular or postcoital bleeding, foul smelling discharge, pelvic or back pain, urine or rectal complaints, and weight loss. Differential diagnoses include carcinoma cervix, endometrial carcinoma, endometrial polyp, atrophic vaginitis, and ovarian carcinoma. So differential diagnosis based on history. So cervical causes in case of carcinoma cervix, supporting history can include postcoital bleeding, foul smelling discharge, multiparity with a visible growth. In case of chronic cervicitis or erosion, persistent spotting, mucopurulent discharge, no weight loss. In case of uterine causes like can be endometrial carcinoma, endometrial hyperplasia, endometrial polyp, atrophic endometritis or vaginitis. Endometrial carcinoma can be associated with obesity, diabetes, hypertension, prolonged unexposed estrogen exposure, nulliparity, and profuse bleeding. In case of hyperplasia, there will be recent hormone replacement therapy, tamoxifen intake, obesity, irregular heavy bleeding. Endometrial polyp will be painless, intermittently spotting, and mild overflow. Atrophic endometritis, recent menopause, scanty spotting, and dryness and dyspareunia will be associated. Ovarian causes like granulosa or theca cell tumor, the post-menopausal bleeding, there will be mass per abdomen and hyperestrogenism features. Iatrogenic causes, for example, hormone-related bleeding, history of estrogen therapy, early menopause and mild flow, anticoagulant-induced bleeding, history of cardiac diseases or stroke or anticoagulants, coagulation disorder, early bruising, prolonged bleeding elsewhere. So coming to the investigations, pap smear to rule out cervical carcinoma, transvaginal ultrasound to measure the endometrial thickness. If it is less than or equal to 4 mm, it will be benign, and if it is more than 4 mm, biopsy is definitely indicated. And colposcopy, directed cervical biopsy, and endometrial sampling or fractional curettage are also to be done. Coming to the investigations, MRI pelvis or CT abdomen are done only for staging after confirmed diagnosis, chest X-ray for any metastasis involvement, cystoscopy and proctoscopy to rule out any anal or bladder involvement, and renal function test. So the algorithm for postmenopausal bleeding is first confirm there is a postmenopausal bleeding, then speculum examination and biopsy the lesion. If there is no lesion, then do a pap smear and a transvaginal ultrasound. If the endometrium is greater than 4 mm, do a biopsy and manage as per the report. General management include correcting the anemia, treating the infection, improving the nutrition and psychological. Coming to the endometrial pathology involvement, hyperplasia without atypia, progesterone is involved, and atypical hyperplasia or carcinoma, total abdominal hysterectomy with bisalpingo oophorectomy is indicated. So a follow-up every 3 months for 2 years, and then every 6 months for 3 years, and then annual thereafter with the pap smear and other examinations. Actually, prognosis depends upon the stage at the time of diagnosis. Early stage, there is a greater than 80% 5-year survival, and late stage usually will result in poor prognosis. Prevention aspect include routine pap smear screening, HPV vaccination, and public awareness. So to summarize, permanent cessation of menstruation due to ovarian failure is menopause, and main symptom for postmenopausal bleeding is always abnormal. Any bleeding is always abnormal. Commonest benign cause is atrophic endometritis or vaginitis. Commonest malignant cause is carcinoma cervix. Diagnosis step is biopsy of the visible lesion. Main investigation is pap smear, TVS, and biopsy. Management of carcinoma cervix, surgery or chemoradiation depending on the stage. Prevention include regular pap smear screening and HPV vaccination. And post-menopausal bleeding itself is a red flag sign. Always rule out malignancy. Systemic evaluation is essential. Early diagnosis improves the prognosis. I hope you have learnt from this presentation. Thank you for watching.